Our next speaker is one of the international guest speakers, Professor Hoffman, who's Professor of Pediatrics of Medicine and Chief of Division of Allergy, Immunology and Rheumatology at UC San Diego. And his lab was the first to identify mutations in NLRP3 as a cause of autoinflammatory conditions. So welcome to Garvan, to Sydney, Hal, and we look forward to your talk. Thanks.
Well, I'd like to thank all the organizers, Mike, Marcia, Tri, and all the rest, for a real hosting a really wonderful time here in Australia. Today, what I'd like to do is give you my sort of outlook from a general perspective. I hope that the talk can translate both to the clinicians, the researchers, and also the patients that it's also great to see here in the audience. But what I hopefully also plan to do is show you a lot of surfing pictures. And you'll see that for sure. So what I'll start with is a little bit of my general view of the way we look at immune disorders. I'll talk a little bit about some of the recent results that came out of the Autoinflammatory Disorder Classification Criteria Consensus meeting that just was held in Genoa earlier this year. And then a little bit about just sort of newer autoinflammatory and immune disorders. And then I'll spend the rest of the time talking about our diagnostic approach. A lot of that is genetics, which has been an amazing thing, particularly in the autoinflammatory field. But I'd like to talk a little bit about some of the drawbacks and some of the pitfalls of actually genetic diagnoses. And I'll use CAPS as an example. You've already heard a little bit about some of those pitfalls in some of the other talks earlier today. I'll talk a little bit about the practical approach to diagnosing rare diseases, both from a physician side and a patient side. And then I'll just finish up talking a little bit about our experience in San Diego with a fever clinic where we see patients with recurrent fevers. So my general idea, and I sort of think things very simply, is the immune system can be messed up in a couple different ways. One is either not enough immune system, which leads to immunodeficiency, and the other is inflammatory disease, which there's multiple different types. Autoinflammation is sort of what we're talking about today. Unfortunately, this is way too simplistic because what we're learning as we learn more about different diseases is there's really no disease that fits exactly in either category. And so we're seeing many of the immunodeficiency diseases that now lead to a lot of inflammation. And we're also seeing classically inflammatory diseases leading to problems with the immune system that then can predispose them to infection. So it's really a push to actually think about immune diseases as really immune dysregulation disorders as sort of the big all-encompassing way to look at things. So the way that we've heard a little bit about this earlier, the way we've sort of separated it, and this is actually what determines sort of the specialists that take care of patients with immune disorders. You have immune deficiency, immunologists take care of those patients. You have allergy, which is an inflammatory disease, and allergists take care of that, and then the rheumatologists take care of the autoimmune diseases. But as we've known, there's always been a number of diseases that don't fit into those nice, neat categories, and for that reason, the patients, in many cases, don't have a good medical home because they don't fit nicely. And that's really where some of these diseases like gout and Still's disease are some of them, but it was really the hereditary fever disorders that really forced it to the front, and that's where the idea of autoinflammation has really come from. So I know that Mike said this is the first real autoinflammatory Australian meeting, but I'm sorry to say that actually we had an autoinflammatory meeting yesterday at Manly Beach. This is actually our board meeting that happened right before the meeting, and then each of us gave presentations. This is Ollie, and he said this was the best waves he's ever caught. This is actually Alicia, and she said this was the best day of work ever, with a big smile. And this is me pulling into a closeout barrel, thinking about autoinflammatory diseases, which is what I do all the time. Exactly. So anyway, we've heard about the definitions of autoinflammatory diseases. I sort of look at them like our previous speaker, Dr. Wininger. I sort of think of them as, in a lot of ways, as exclusionary. They don't fit into immunodeficiency necessarily. They don't fit into IgE-mediated disease. They don't fit into autoimmune, and they're primarily innate immune-driven. Unfortunately, I've seen autoinflammatory disease patients that seem to have more infections and do have IgE-mediated disease, and then also can have autoantibodies. So again, these nice new classifications don't work that well when you really see real patients. It's nice in that the hereditary fever disorders all sort of had these shared characteristics, and I think that's what made it easy for us to sort of come up with this first definition. And then the genes actually helped us to better understand the pathophysiology and be able to sort of understand all the different connections between these different diseases in terms of TRAPS having effects on the NLRP3 inflammasome and HIDs having, and the isoprenoid end products having effects on the pyrin pathway. It all sort of brings everything together with IL-1, which is why IL-1 is our biggest drug that we use in these particular diseases. So what I wanted to do now is talk a little bit about these criteria that were developed. And so what happens is it's important to develop both diagnostic criteria to help our physicians actually make the diagnosis, also help patients make self-diagnosis, and I do think that's an important part of this whole process. There's also this thing called classification criteria, and the main reason for that is to create these standardized definitions in order to oftentimes define a population that can be used for clinical research. And this usually takes care of these well-defined homogeneous cohorts, and it's usually applied to a group, not a particular patient themselves. It oftentimes uses high prevalence features, and in general, the goal is to have high specificity. So you want to be able to really pick out the right patient, but you lose the sensitivity when you create these classification criteria. On the other hand, there's a diagnostic criteria. Those are actually supposed to be what the doctors are using in the trenches. It is clinically useful. You look at signs, you look at symptoms, you look at different tests, and you try to come up with that one individual, what that person has. In general, you want to be broad, you want to try to capture, but you want to be both sensitive and specific. And so what we a lot of times do is try to create these diagnostic criteria, and also I'll talk about the classification criteria, in order to best sort of deal with the specificity and sensitivity issues. So this was a diagnostic criteria that just came out this year for CAPS. And you can see that it already doesn't fit that well because it actually has as a main indicator to have raised inflammatory markers. And what I'm going to show you later today, and what we heard about earlier in Melanie's talk, is patients with fairly classic autoinflammatory diseases that don't necessarily have elevated markers. And that's really created a lot of stress in those of us who see these patients. But then we basically pick out a certain number of primary signs and symptoms in addition to those raised markers that then give you the diagnosis. It was a little bit of a challenge to put this together in CAPS because CAPS is this sort of spectrum of diseases, which we'll talk about a little bit later. But in general, if you pick these particular things that are very unique and make those the important ones together with the inflammatory markers, you have a good chance of being able to diagnose CAPS. So what happened is in Genoa this year, we met and it was all the autoinflammatory disease experts, not all, but many from all over the world. If you can imagine, it's lots of different personalities, lots of different countries all coming together, with a lot of experience taking care of patients. We had a group of primarily clinicians and a group of primarily geneticists, and we all had to do a lot of homework before we actually came to this beautiful place in Genoa earlier this year. And that homework was we had to go through 400 cases, 450 cases that had been collected through the Eurofever project and actually make our diagnosis and determine what about that patient made us want to make that diagnosis. So we actually went through all 450 of those patients, made a diagnosis, and then at different stages we got to see what other people were saying that the diagnosis was. And then after that, after going through that whole process and then looking at again the sort of reiteration, we then find out what their mutation or lack of mutation, and then you get to go back again and sort of figure out to be able to create a consensus based on all these different experts. So it was a really exciting and interesting process, and I do feel it was actually useful. So what I'll do is I'll go through just briefly and show you what the results of that consensus conference came up with. And what I'll tell you is that we had sort of multiple levels of sort of making of classifying these diseases. Some was based on genetics. Some was based on how sure you were about the function of that particular mutation, and some were based purely on clinical criteria. So in general, what you'll see with each of these different of the four main diseases we talked about, there's sort of the first, which is you have a mutation that is a known or at least have been associated with several different patients, and then you only have to have one of those particular clinical criteria in order to meet a classification criteria. If you end up with a variant, it becomes a little bit more stringent, and you need to then have more clinical criteria. And then when it comes to just a clinical criteria, it's very similar to the diagnostic criteria that we just showed you earlier. For FMF, there have been tons of diagnostic criteria that have come out and classification criteria. But we wanted to create something that, again, was based on the genetics and then not based on a treatment response, which a lot of FMF criteria are based on a response to colchicine. When it comes to the clinical criteria, this actually looks very similar to what some of the recently published diagnostic criteria are. So there is definitely an overlap between classification and diagnostic criteria. But again, they have sort of different points. TRAPS, on the other hand, we were able to come up with a genetic, but when it came to the clinical, we could not come up with a consensus of a clinical classification of genetics, and that without genetics, and that actually has stressed out a lot of people within the community. And finally, here's the results for MKD, and it is primarily driven by the genetics, as you can tell, but there is also a clinical characteristic as well. So at the end of the conference, we all sort of were able to come. This is actually going to get published fairly soon, but the goal of these criteria are to hopefully be able to do more clinical research, be able to classify patients a little bit better. But you can still tell there's a lot of overlap, and so even though you can pick out certain clinical features, when it comes to actually seeing patients, these criteria may not actually help us out that much. The real bummer is that there were absolutely no waves in Genoa at all, so no surfing there. What's happened is there is now obviously autoinflammation has expanded a lot more. In addition to these hereditary fever disorders, there are these other IL-1 mediated diseases that we've heard about, DIRA and DITRA, as well as NLRC4. But now it's not only IL-1 and fever anymore, it's also about all these other different genes that, again, I think are telling us more about immune dysregulation, not necessarily about just purely autoinflammation. And so there are more and more diseases that are sort of coming out, and you can sort of classify these diseases as either IL-1 mediated, interferon mediated, NF-kappa B mediated, or persistent macrophage activation, or as of yet uncharacterized pivotal pro-inflammatory mediators. And these are sort of ways to think about it, but in general, I think these are all just immune dysregulatory diseases. So we can sort of be splitters or we can be lumpers, and I tend to sort of just lump them all together. It's an immune dysregulation. And this is actually a way to sort of think about it in terms of autoinflammation, immunodeficiency, and autoimmunity, and then with these polygenic disorders in the middle that actually have parts of all these different immune dysregulation. All right, so I'll move to the next part of my talk, which is really about genetic diagnosis. And that again, has been an amazing advance in our way of taking care of patients. And I think in the future will become the way we actually look at a lot of patients. But there's still a lot of issues with making genetic diagnosis. First of all, patients don't follow the rules. We initially think a disease is recessive, like FMF, and then find out that one mutation may actually be enough. So there's actually a gain-of-function mutation is enough, and you don't necessarily need to have a loss or two different mutations. Mutations don't behave the same way, and we saw that in Melanie's case, where you have some patients that are totally fine with R92Q, and then others that seem to be severely affected. And I'll give you some examples of that later when I discuss some of the stuff with CAPS. And what we're learning about even more now that we do more sequencing is that there are many patients that have multiple different disease mutations. in multiple different disease genes. So they're more, instead of being a monogenic disease, it's really an oligogenic disease. Somatic mosaicism has really dropped everything on our head. I think it completely messes up my way to sort of think about genetics and be able to counsel patients on what's coming in the future. And then there's this, for all of us who do genetics, there's the variant of unknown significance, which really is a part of the process that's very difficult to deal with in many situations. So what I'd like to do is sort of illustrate some of the challenges of sort of making genetics, basing everything on genetics with CAPS. And so this is the NLRP3 gene that we found years ago. Cryopyrin is the protein that it makes, and if you can see, most of the mutations initially that we found were in that sort of central part of the protein, the NOD domain. But things have changed since then. It was really exciting to find out that it's not just mutations don't just cause FCAS, but actually lead to Muckle-Wells syndrome, as well as NOMID. So now we had this complete continuum of diseases. Again, this is another example, though, where patients don't follow the rules. And we have patients that don't have FCAS or Muckle-Wells, but actually have a combination, and I call them FCAS Muckle-Wells. Or patients who have milder NOMID or more severe Muckle-Wells, and we call those Muckle-Wells NOMID. You can continue to split out, and you can actually have Muckle-Wells NOMIDs, and NOMID Muckle-Wells. I mean, you could go all over, but in general, it is one particular spectrum of disease, and which is still important to look at the subphenotypes, because I think it helps us both in counseling patients and also in how aggressively we want to treat them. So while it's one disease, I still like to be able to separate the patients out into different subphenotypes. The beauty of this particular disease is it actually has pretty remarkable genotype-phenotype correlation. And what that means is if you have a particular mutation, I'm more able, or clinicians are more able to be able to expect what that patient can expect in the future. There are now over 90 different mutations that have identified since we identified the first 3 or 4 back in 2001. And again, for the most part, we do see fairly good genotype-phenotype. Again, like our patients, we do see these mutations that cross over and give you sort of FCAS Muckle-Wells, or others that give you Muckle-Wells NOMID. But in general, to have that kind of genotype-phenotype correlation is actually a little bit unique in diseases. But there were some complicating factors. First of all is the variants. And actually one of these variants, V198M, we actually published as a mutation in our first paper. It turns out it's not a clear mutation. It's actually a variant. It's actually low penetrance and does show up in patients that seem to have no disease at all. Talk a little bit about these variants. There have been some publications recently focusing on a few of these. There's one called the Q703 variant, which a large population of patients, 57 patients with this variant, had this Q703. And in general, it had a similar allelic frequency for control population. So from a geneticist, that means it means absolutely nothing. And when they did some experimental in vitro experiments in the lab, they didn't see anything classic with CAPS. And so what they concluded was this was, if anything, a weak or and really no significant effect. What we did is we actually took a population of patients with all 3 of the different low penetrance variants, the V198M, the Q703, and the 488K. And this was a collaboration between Raphael Goldbach-Mansky and Jasmine Kumuli-Deschner. And we took all these different populations from multiple different centers with all 3 of these different variants, and we put them all together clinically to see what happened. And actually, when you do that, you start to see some patterns. A lot of them have some of the sort of non-specific symptoms that we see pretty similarly, but we do see that things like fever and abdominal pain are more common in the patients with these low penetrance mutations, whereas the organ problems like the eye disease, the hearing loss, and the renal involvement seem to be a lot less in the patients with low penetrance variants. So then we went to the process of actually taking any way we could to sort of look at whether or not these mutations actually had any kind of functional effect. And we did it in multiple different ways, not just one, not just 2, but 4 different things to sort of see what we saw. And actually the results were not exciting, but I think are actually sort of telling. Because what we see as we sort of go through each of these different functional assays is we see this sort of intermediate effect. You can see on the caspase-1 activity that the two mutants, the FCAS mutation L353P and the NOMI mutation L264F, have clear caspase-1 activating function. But the others, these sort of variants, have a little bit more. Only one of them is actually statistically significant, but it's clearly a little bit more than the wild types. And that's what I think the patients are. They've got something going on, but it's not clearly identifiable. And that's exactly what we see clinically. Similar story with the IL-1 beta release. Again, clear differences in the real classic mutations. And then again, slight increases in IL-1 beta release with only one of them reaching significance. Similar with the cell death assay that we did. Again, slightly higher than wild type, not a lot. And then the NF-kappa B activity, which actually gave us some interesting results that actually was a difference in this one NOMID mutation that we didn't see in FCAS. And then one of the variants actually had a fairly significant increase. So I think as you sort of look at these variants and sort of look at them functionally, they are what they seem as clinicians, is they give you a little bit of something, but they're not quite like the other patients we see. And that, I think that may help us to sort of understand things. What's also happened is that we focused a lot on mutations in one region, like the NOD domain, but just as you heard from Seth talk about earlier, if you look in other regions, you start to find some other mutations. And so while I said most of the mutations were in that NOD domain, there are now some mutations in the leucine-rich repeat domain, including this one mutation in patients that we follow and also another group at the NIH follows that have absolutely no systemic inflammation when you look at them, but they have symptoms and they have this hearing loss that goes along with the Muckle-Wells phenotype. And actually, even though they have absolutely no systemic inflammation, when you give them anakinra, their hearing loss gets better. So it really sort of, again, turns a lot of stuff. I was sort of thinking, you have to have systemic inflammation to warrant being treated. But again, you potentially can have specific organ damage without significant systemic inflammation. There's also been some now mutations in the pyrine domain, similar to what we saw in the FMF story. These mutations are in a different region and lead to a different type of a rash, not the classic rash that we see with others. All right, back to our sort of multi-mutations. The other thing that, again, has sort of turned things on their head from a genetic diagnosis standpoint is somatic mosaicism. Most mutations either are a de novo mutation. They happen somewhere in the sperm or the egg, and then that is what the child has, or they're passed on from a mother or a father. But there are some mutations that actually occur later on in the embryo stage. And when that happens early on, you get a lot of cells affected. But when it happens later in development of the embryo, then you have a very small percentage of the cells. And what turns out, at least in the case of CAPS and a lot of other diseases we're learning about, even a small percentage of cells, only 4% of your myeloid cells that are positive have a mutation, can lead to a full-blown phenotype. So the other crazy thing is that you can potentially then have later onset disease. And so there are situations now where kids have been diagnosed with disease, and then their parent is diagnosed about 30 years, at 40 or 50 years of age, when they start to have disease because they turned out to be a somatic variant, but then passed it on in their sperm or in their eggs. So anyway, somatic mosaicism has really affected things. Not only does it result in late onset CAPS, but and also can be associated in a few patients with Sintra syndrome, although not all. It affects the way we diagnose our patients because typical straightforward Sanger sequencing or even some of our next-gen sequencing doesn't pick small percentages of cells up, and it may not pick it up if you only look at the blood. It affects genetic counseling, where if you normally would say to a parent, this is a de novo case and your next kid's not going to have it, I can't really say that anymore because they could be a somatic mosaic that then could pass it on to their next child. And again, it could also affect treatment, particularly if we start thinking about bone marrow transplants in some of these more severe autoinflammatory diseases. Because you'd really want to make sure you got rid of all of the bone marrow if all you need is a small percentage of cells to actually deal with it. All right, so your question, is it a shark or a dolphin? You can relax. These are dolphins. We see them all the time. I've only seen one shark. But in general, we use these sort of unique features of sharks and dolphins to sort of decide which one it is. And we do the same to sort of make the correct diagnosis. And so what we've done over the years is actually use these sort of unique features to sort of, which either are ethnicity, inheritance pattern, age of onset, specific symptoms that we talked about, type of rash, treatment responsiveness, or the pattern of length of episodes. And this is a paper that Anna and I wrote several years ago that really sort of points to that whole sort of pattern and really listening to the patients to get a good history to help us sort of decide which of these different diseases are going on here. Actually, even though these diseases are called periodic fever disorders, they actually aren't that periodic. If you define periodic as having a period like a wave, if you define periodic as just happening occasionally, then actually they are all periodic. But these pattern episodes are really the history is what does it. And so as different, as physicians, either primary care doctors or specialists, we need to sort of look at the pattern of what we see and try to figure out where to place that patient. And that can be sort of a challenge because there's a lot of biases that we have as physicians. First of all, MDs may not think that they are ever going to see a rare disease, but the truth is, actually, MDs see rare disease patients every day. They just don't see that particular rare disease, because 1 in 10 patients actually have a rare disease. Most MDs don't see patients with a specific disease, as I said, but if you're not looking for it, then you're not going to find it. And so we've got to sort of work with MDs to sort of at least think about these diseases. And it's really challenging to teach MDs about these different diseases because there's so many different diseases out there and so much to learn and so little time. And more of the medical school curriculums are pointing less towards sort of rare diseases and more towards just sort of dealing with common stuff. And so Dr. Broderick and I came up with sort of a table to sort of at least make doctors think about it and patients as well. And so we came up with just 5 signs of autoinflammation. This is something that's well known in the immunodeficiency field because there's sort of these 10 sides of you may have immune deficiency. We wanted to do one for autoinflammation. And so this sort of at least makes people think about it. It's not perfect, it hasn't been validated, but at least it makes people think, and that's kind of our goal here. All right, there's more MD biases. As I said, some of them are that you're never going to see a patient with that disease. A lot of the other problems is just the time. MDs a lot of times need to get through their multiple patients they have in the day, and they just don't feel like they have the time to sort of figure it out. What I like to tell them is that Google is amazing. I can tell you many patients around the world who've contacted me over the years have actually just Googled their symptoms, come up with CAPS, and sent an email to me. And that's a common story. So if a patient can do it, then I think a doctor, who just has a few minutes in the clinic can actually do it as well. But there are a lot of other biases, and these are biases that all of us sort of hold. There are biases that a lot of times we think about a particular disease only the way it was described when it was first described, or when the gene was first identified. And I'm certainly guilty of that. And I've had patients come to me saying they are sure they have CAPS. I tell them, no, I've seen hundreds of patients with CAPS. You don't have CAPS. And then the sequencing comes back and they have CAPS. So even I can be wrong. The other thing is it's very dependent on what you see as a physician. And so the first patient you see, you sort of apply that to all the other patients you see. And the other thing that really biases physicians is actually the specialty. And this is one problem with these patients, autoinflammatory disease patients, not actually having a medical home. So when you go to a barber, you get a haircut. If you go to the pediatrician, you're going to get immunizations, and you're going to get someone who's thinking a lot about ear infections and colds. If you go to the internist, he's going to think about medicine interactions. If you go to the rheumatologist, he's going to be thinking about immune disease, infectious diseases, obviously infections. Immunologist, immune deficiency. Hematologist, oncologist, got to be cancer. Gastroenterologist, IBD, and dermatology, as we heard, lots of different nasty rashes. But it changes the way we think about things. And so I think as we move in talking a little bit about our fever clinic experience, we are actually coming from an allergy immunology background, and so we think about patients from that sort of standpoint, but may actually not think about them as much from the others. So we actually welcome our patients actually seeing multiple different specialists just to make sure we're getting the perspective of all the different specialists. So it's not just MDs that have the biases, patients have the biases too, and that can cause a problem. First of all, patients a lot of times will pin everything on what their first doctor told us. We have many patients that come to us saying, my doctor told me I have this, and you can't tell me I don't. In many cases, we have to say, no, you don't. Many times patients are reading stuff on the internet, and I actually approve of that, but you got to take it with a grain of salt, because a lot of times what you're reading on the internet may not actually be a patient with that particular disease. You have no way of sort of confirming what's going on. The other thing is patients don't want to have a disease in general. And if they do have a disease, they want to have a good disease, a disease that doesn't sort of commit them to medicines their whole life, something that may go away or something like that. But unfortunately, sometimes you don't have a good disease. And then we do have a few patients that actually seem to get invested in having a rare disease. And I understand that. Once you've been through the process of not knowing what you have and finally get a label, it sort of gives you some freedom. But you can't be defined by your disease. You're different, and just because you may have a disease doesn't mean that you're actually going to be like everyone else or be like what the published cases are. So those biases that the MDs and the patients have, I think we need to work with. And that's why it really takes a team to actually put together, take care of patients with rare diseases. It involves using patient support organizations like the Autoinflammatory Alliance, having family to sort of help you, and that's particularly important when other family members have it and understand. Doing a good job of getting a history for your doctor actually makes a difference. So we really suggest diaries are really important, and actually getting together records. And doing all that really helps. And from a physician standpoint, also acting as a team, going in, looking at the medical record. And more we just don't have the time, even though it's right there to look at. But getting a geneticist input, getting a genetics counselor input, getting the disease expert input as well. All right, so sort of a lot of times for the patient and the sort of the journey to sort of get to a diagnosis, their goal is to sort of find something that explains everything, a unifying diagnosis, and ideally, which doesn't happen that often, but can happen, you actually get a cure for that particular disease. But in reality, it's not quite that clear. A lot of times there are unclear diagnoses. We've heard some of those earlier today. Sometimes they're complicated. There may be multiple different mutations or multiple things, or no diagnosis at all, which is stressful, but sometimes better than having definitely better than having a diagnosis that you know is not going to be good. And again, the cure is not always there. Oftentimes, as in the case of CAPS, you get a lifelong therapy, which is certainly better than no therapy at all. You may have to go into investigational trials. You may have to go on some dangerous therapies as well that may actually be worse than the disease. And in worst case scenario, there's no therapy at all. So in general, the genetic diagnosis, I think, is a good thing. And I wanted to sort of explain it in both good and bad ways, but it doesn't necessarily equal a cure. And it's more important to actually have a teamwork to actually work to have a plan. So a little bit about our fever clinic experience. We started it back in 2010 at one of my colleagues, Dr. Broderick's suggestion. And since that time, we've made multiple diagnoses. And we basically are where all the different specialists send us. But we continue to work closely with all the different specialists. For the most part, we see we see very few kids with hereditary fever disorders. What we do see is a lot of kids with recurrent fevers. And out of those, probably half of them, well, actually, out of many of those, they don't even have recurrent fevers. They just have recurrent infections. But out of the ones that do seem to have really recurrent fevers that are non-infectious, about half meet the sort of FAPA criteria, and we're pretty strict about that criteria. And the other half meet another group of patients that we call syndrome of undifferentiated recurrent fever. I'm sure you can understand why I like that name. And so that's the way we sort of look at it. We have the hereditary fevers on one side, the FAPA patients on the other, and the SERFs in the middle. And as we sort of watch them, over time, they may migrate towards one side or the other, or it may just go away. So take-home messages for clinicians and for patients. The immunologic disease classifications are changing. I favor a more all-inclusive. These are immune dysregulation. Autoinflammation is expanding beyond IL-1 for sure. Genetic diagnosis is amazing, but is not a straightforward process. Diagnosis can be challenging, both for MDs and for patients, and what really takes is a teamwork and a lot of patience on both the physician's part and the patient's part to sort of make this work. This is one of Mike's many hidden talents. I'd be happy to answer any questions.
Is there some questions? Yes, Kate?
Thanks, Kate.
Something that's always fascinated me is, NLRP3 usually requires an activation signal in order to form the inflammasome and signal. Are these mutations promoting signal-independent inflammasome assembly, or are they sort of lowering the threshold for NLRP3 activation so that NLRP3 can now be activated by more minor disturbances in cellular homeostasis? I'd be fascinated to have your thought.
I think it's a little bit of both. And I think that may be where the continuum really comes in. I mean, it's really clear from our ex vivo studies from both our mice and our patients in FCAS that they really have not much going on until you give them a little bit of cold stimulus. Whereas the Nomen mutations seem to have sort of something a little bit more going on a regular basis, and we see this both in patients and in our mice, in which we have sort of a whole continuum. So I think the answer is both. It's sort of semantic, though, I guess. In a lot of ways, could it just be that, the threshold is, you don't reach the threshold until you do something. That's kind of, in general, what some of the newer data is showing is this sort of, these effects on phosphorylation. So that would sort of assume some sort of a switch that needs to be sort of turned on and not necessarily turned on all the time, but I'm not sure.
Hal, maybe I could ask you, sorry, Anna, go ahead.
Thank you for the talk. I had a specific question about the variants in NLRP3 and the studies you did with all the caspase-1 and the IO and beta. So were these all from people who were referred to a fever clinic, or did you also include just a general population that were not referred to a fever clinic but were carriers of the mutation? Might that have an effect?
Yeah, so what we looked at in the clinical characteristics, we looked at patients with definite CAPS mutations, and then our controls, those were our controls, actually, for the patients with the low prevalence variant. So we didn't actually do non-mutant patients to sort of look at it.
I mean, general population carriers of the variants who might not have fever enough to be sent to a clinic or might not have fever at all.
Right.
Were they included in the pathophysiological studies?
These are patients that had just come to a fever clinic.
So they did. So
exactly.
There might be a bias there that you are picking out the inflammatory patients.
Right. Exactly.
Right.
Yeah, I think that's an issue. And if you look at it, I guarantee you'd find lots of patients that don't have a lot of symptoms.
How could I just follow up on the somatic mosaicism and the low penetrant variants? So you showed your bioassays, and the low penetrant variants didn't have much of an effect, but they were clearly pathological because the patients had some features. Right. But then in the mosaics, you said some patients you just needed 4% of your macrophages or monocytes to be mutation positive. So how can you reconcile those differences? So you've got a penetrant variant, a low penetrant variant, which has a very mild biological effect in an in vitro assay, right. Which you may look at and think it's very, very hypermorphic at best.
Right.
But then you can have 4% of your macrophages causing disease. So are we looking at the wrong cells in vitro for your assays, or is it all context specific?
Good question. So I can reconcile it because I sort of feel like the low penetrance variants are really a different mechanism, whereas the somatic mosaics are all clear gain of function mutations in a system in which you don't need much to sort of start this cascade. So
the mutations found in the mosaics, if you tested them biochemically, would they be 100-fold better than gain of function would be 100-fold higher than wild type, for example, to show the same level of increase at a 4% of cells?
We haven't done those experiments, but in general, you saw those are two, our controls for those variants were actually two, and you saw that they were much, much higher, at least for caspase-1 activity, IL-1 beta, for cell death. So yes, a lot more than wild type. But you're right. Should you expect those in small? I don't know. I think it's a quantity versus quality sort of answer. It's kind of the way I think about it. But.
There's some questions up there.
So Hal, just quick question is, with the CAPS patients, they seem to have sensory neural loss significantly more often than any other periodic fever. So more than FMF or HIDS. And so why is that, given, we've just seen HIDS and FMF, they almost through the same pathway, interleukin-1. What makes CAPS so special about your hearing?
I think it's a really good question. and it comes down to some of the same questions that Seth was asked earlier, sort of why do these patients that have very similar pathways all have IL-1 as a general, as a downstream mediator, have different characteristics. We do know that a lot of patients with some of the other fevers do have CNS stuff that's not really recognized. A lot of them do have a lot of headaches and things like that, and so probably do have some CNS inflammation. But there's got to be something special about NLRP3 and its expression potentially in hearing cells, and that's things we're working on right now in our mice, because we actually do get a hearing phenotype in our mice. So I do think there is something special about the actual expression of NLRP3 in some CNS cells.
I'm not sure if I should explain that belly dancer photo or not. Thanks for showing that. Perhaps I won't. How much do you think the microbiome influences the clinical phenotype or the variability in the clinical phenotype in patients with the same mutation?
Yeah, it's a hard question because we really haven't looked at it the way we need to from the microbiome, and it's also a difficult thing. What I can tell you is we've had we have patients, and our mice actually for that matter, that actually come out of the womb with symptoms. So it's hard. Again, the womb is not a sterile environment either necessarily from a microbiome situation, but it's hard to put too much into the microbiome if it's really that way right as they come out. But we also have patients that have fairly clear caps that don't really seem to have any symptoms, even though the parents are looking for it until they're 3 or 4 years of age. Some seem to happen after immunizations. I'm certainly not one to argue against immunizations because I think it's going to happen at some point. That was just the thing that sort of did it. In our mice, at least, and again, mice aren't humans, so I would say the answer for the humans is I can't tell you. I don't really, we can sort of, from history and sort of talking to lots of patients, which I've done, hard to say. From the mice, what I can tell you is we've given our mutant mice to some collaborators who have extremely clean environments, and there's a very big difference in the phenotype. So I do believe that that potentially that thing that could be determining what Kate was asking about, whether or not this is a little bit of a constitutive activation or just I think it'd be a real modifier there. And while we say autoinflammatory diseases are non-infectious, that's probably true, non-pathogenic infectious, but maybe autoinflammatory diseases are actually really just a microbiome, a sensitivity to sort of microbiome changes. And that could explain a lot of periodicity that Anna was talking about earlier, or that Seth was talking about, in addition to sort of the mechanisms we use to sort of to control it. But I think it's complicated.
Hello. Yes. Go, Seth. Thanks.
Hal, that was great. Can I ask about the low penetrance variants as well? What's your experience been with treatment? You might imagine that if the IL-1 beta is only part of the story, something else is going on, and maybe you don't have as good responses to blocking IL-1 in this subset of patients.
And that's in the exact, yeah. And if we want to get responses, a lot of times you have to use much higher doses, or they just don't respond as well. And we've seen similar situations with the TRAPS low penetrance. Actually, Melanie talked about in her talk about the patients and responding. But actually, the patients in the cluster trial that she showed a little bit of data on, which was the monoclonal IL-1 beta, they did not exclude R922Qs. And actually, the patients that didn't do that well in the TRAPS cohort, actually, when you take it out, were actually the 92Q patients. So they don't respond as well as you would expect, which, again, I think goes together with sort of there's a little bit of something wrong, and it's not quite all about IL-1. Maybe it's NF-kappa B directly. Maybe it's adaptive immune system. All kinds of different possibilities. But yeah, that's generally been our experience, is they don't respond well. It doesn't mean you don't try it, and that we sort of give, depending on, you got to make the decision, like, Melanie was talking about, is it worth treating? Do you want to, weigh the risks and benefits of the patient having enough symptoms to actually do the treatment? And then, how hard you're going to have to go to use it. You may have to go to higher doses.
All right, we better move on. Thanks very much, Hal. Fantastic talk.